Good morning everyone, and welcome to the fourth webinar in the Sussex Population Health Academy series. It's great to have you all with us as we explore the critical topic of equitable commissioning for population health. So for those of you who don't know me, my name is Lucy and I work for Health Innovation Kent, Surrey, Sussex, and working on the Population Health Academy. It's a great privilege to be here together working with the Sussex Health and Care System to deliver these sessions on key population health topics. So today we're delighted to be building on the learning from earlier webinars and by focusing on topics based on insights captured from the last series and current evolving needs. So we do have quite a lineup of speakers lending their respective perspectives to help us all achieve our intended outcome today of applying equitable commissioning to reduce barriers and ensure access for all. So as well as myself, our speakers will walk us through a combination of case studies and local plans that help make equitable commissioning real for the people we serve. So before I hand over to our first speaker, I just wanted to set a little bit of context around the importance of equitable commissioning. So commissioning might sound like something only a few people directly deal with, but the truth is it touches us all where we live, where we work, and in the communities we're part of. Each decision is about how services are funded and delivered and shapes the care people receive and the outcomes they will experience. So you might have heard of the triple aim. It's a guiding principle in healthcare that asks us to consider how every decision impacts three things. One, improving health and well-being, especially by reducing inequalities. Secondly, enhancing the quality of services for everyone. And third, using NHS resources sustainably to ensure long-term value. And more recently, that triple aim has evolved into the quadruple aim, which also recognises the importance of health and well-being of the workforce who provide care and support, which is a key factor in improving the way health and care is delivered. So this isn't just a policy framework, it's a call to action for all of us, regardless of role or sector, to work together and listen to the people we serve. So today we'll hear how Sussex is putting this into practice, blending strategic policy with real stories to change through equitable commissioning. So I do hope by the end of the session you'll feel better equipped to see how your role directly or indirectly can help shape a healthier future for everyone in Sussex. So without further ado, I'll hand over to Jo Allner and so we can get started. Over to you, Jo.
Fantastic, thank you ever so much. So welcome everybody, it's fantastic to see you all here. We've got nearly 50 people here, so that's great, and I'm sure that will grow in the next few minutes too as people start joining us. But I'm Joanne Allner, for those who don't know me, and welcome to the fourth of our webinars from the Population Health Academy on equitable commissioning for population health. So it's fantastic to see so many of you joining us, and I'm excited about the conversations we're going to have today in respect of the speakers that we are having with us to present to you, but equally what that raises for you for questions and in relation to your roles, no matter what they are. And I think that will be the message today. It doesn't matter what your role is within the health system. This is relevant to you, even though commissioning.
Isaac, can you get up, please?
Someone just put their...
If everyone can please mute their microphones.
Okay, thank you. Now, I appreciate that when we talk about commissioning, it can sometimes feel like a technical term reserved for specific roles. But the truth is, commissioning is everyone's business, and at its core, it's about decisions that shape how resources are used, how services are designed, and most importantly, how we meet the needs of all the people we serve, particularly those who have been historically underserved. And that's the important part of that sentence in relation to today's webinar. We are talking about those who are historically underserved. It links to our STP. Sussex Shared Delivery Plan is clear in its ambition to improve health outcomes and reduce inequalities across our communities, and to do that effectively, equitably, commissioning needs to be front and centre. This means making sure that every decision we make, whether it's about funding services, designing care pathways, working with local communities, or even actually delivering services to patients, no matter where we are in that process, that is focused on fairness and driven by data, need and lived experience. Now I'm going to hover around that word fairness for a moment with you, because this is really important for today's webinar. You will notice we are not talking about equal commissioning for population health. We are talking about equitable commissioning for population health. So it's important to understand what the term fairness is in this discussion. Now, fairness isn't about being equal. Equal means each individual or group of people is given the same resource or opportunities. It assumes an equal playing field. It assumes everyone has the same opportunities in life, have their same health outcomes. But we know that's not the case. And we know that's not the case in Sussex. We are no different to anywhere else in the country or in the world, actually. But Equitable recognises that each person has different circumstances and allocates the exact resources and opportunities needed to reach an equal outcome. So to do equitable commissioning, we need to recognise the inequalities in our population, and we need to think about how we drive resources, finances, investment, people, focus of attention, and look at their opportunities that they need to reach an equal outcome, which at the moment they're not having due to their protected characteristics from their areas where they grew up, their level of income, their level of education, which are all things which, if you don't know, I'm sure you'll hear more about today. But I know that message has got out quite loud and clear, especially through COVID. So this is what equity means. So be careful when you use the word equity, and make sure you really know what you're saying when you say you want to do something equitable. It is about focusing more on certain groups and not equally. It links to national policies, with recent policy shifts, including the focus on strategic commissioning outlined by NHS England, and have reinforced the importance of working across our system. Commissioning today isn't just about contracts. It's about partnerships, co-production, and designing services that address the social determinants of health in a meaningful and sustainable way. And that is a role for anybody, no matter what your role is. We've got great speakers today, all from Sussex in the system, so they can really talk about what we're doing locally and the challenges and the aspirations that we have. They'll explore how these principles around the health equity principles, which we shared before, but we'll remind people of those today, how they're applied in practice, and whether through strategic frameworks or real-world case studies. But as we move through today's session, I encourage you to think about your role in commissioning, directly or indirectly. The decisions you influence, big or small, are shaping the future of health and care in Sussex. And together we can make sure that future is equitable, inclusive, and focusing on improving lives for everyone. So thank you again for being here with us today. We've just gone over the 50 mark. That's 51. That's great. And I look forward to us all having a great conversation and learning together. Thank you.
So next slide, please, Sharon. So yeah, for those that have joined the webinars previously, you'll be familiar with the 10 principles for health equity framework that we developed at Health Innovation Kent, Surrey, Sussex. And at each webinar, we dive into a couple of principles, do a bit of a deep dive. So the two principles today that we'll be looking at are people and finance. You can move across to the next slide. So the people principle is really about seeking out information about different user groups, for example, exploring inequitable health distributions by different demographic factors, and identifying which communities will be using or most effective by the service or intervention. It's about considering what kind of inequities different communities might experience and engaging with those communities to understand what's needed, so co-producing services, and understanding what kinds of barriers they may face in order for services to meet the needs for all, particularly those who face the most challenges, as Jo mentioned earlier. Next slide, please. I'll talk to the finance principle. So the principle around finance is about mitigating against financial barriers that communities face in being able to access services or interventions, and it's about supporting solutions that will reduce acute care costs and help deliver an invest to save model for the NHS. So it's also about considering whether the intervention or service is adequately funded to ensure successful implementation, and identifying those that are at risk of financial hardship and which groups are most disadvantaged financially in relation to accessing the service. It's also important to consider how adverse financial impacts can be prevented or minimised, and to support solutions that reduce the impact of the cost of living crisis. It's still not moving along, Sharon. Did you want me to? Oh, there we go. If you can, that's it. Perfect, thank you. So yeah, I'll talk to you now about the Commissioner's Guide for Health Equity. So this has adapted the 10 core principles into a guide and resource to support equitable commissioning for both commissioners and service providers. And the guide follows the commissioning cycle so that health equity can be embedded within each stage of the commissioning cycle. If you move along. So during the strategic planning phase, it's essential to conduct thorough needs assessments to identify the specific health needs of different communities, particularly those facing health inequalities. And this involves gathering and analysing disaggregated data on factors such as socioeconomic status, ethnicity, disability, and geography. Understanding the unique challenges and barriers that these people face enables commissioners to tailor services more effectively to their needs, ensuring that the most disadvantaged groups receive appropriate care and support. And by engaging with local groups, service users, and community organisations, commissioners can gain valuable insights into the barriers these populations face and the kinds of interventions that would be most effective. Co-production helps ensure that services are designed in a way that is culturally appropriate, accessible, and responsive to the needs of those who are often overlooked in traditional service models. And resources should be allocated in a way that disproportionately supports those in most need. This might mean directing more funding or services to underserved areas or groups who have the greatest health needs, ensuring that investments help level the playing field. Next slide. So in the procuring services stage, it's essential to involve all communities and stakeholders who will be impacted to co-produce services and develop a shared vision. This will also involve co-producing inclusive messaging to ensure information is being heard and understood in the right way. It's also important to consider the system and workforce needs in which a service or intervention is being commissioned. This will include understanding what education and training needs are needed, as well as ensuring the workforce are promoting equality, diversity, and inclusion, and engaging with each other and patients in a culturally inclusive manner. Financial barriers and adverse financial impacts on certain communities need to be considered, as well as how to mitigate these when procuring services. So this might include considering costs to patients, such as travel, time of work, parking, or prescriptions, for example. Considering digital solutions can also help mitigate access barriers, such as through telehealth and at-home testing, and services could be blended in terms of offering both digital and non-digital solutions to help promote equitable access. And next slide. So monitoring and evaluation are essential components for commissioning services, especially when aiming to address health inequalities. Monitoring and evaluation ensures that commissioned services are reaching and effectively supporting those most affected by health inequalities. So by using data, along with feedback and insights from communities and the workforce, it's possible to track specific health outcomes in different demographics, and it becomes easier to assess whether services are making a tangible difference where it's needed most. This data can highlight gaps or areas requiring improvement and adaptations in service delivery. So effective monitoring and evaluation helps identify where resources are being allocated efficiently and effectively to address health disparities. If certain services or interventions aren't producing the intended results, those adjustments can be made quickly, optimising the use of funding and helping ensure equitable access to care. So the insights gained from monitoring and evaluation inform future commissioning decisions and lead to more targeted interventions and reinforces the focus on equity in healthcare provision. So next slide, thank you. So supporting the guide, we've developed a health equity assessment tool, which can be used by both commissioners and service providers throughout the commissioning cycle to help ensure that health equity is being considered throughout it. So this can be downloaded as a resource. It's included within the guides, and to help kind of consider health equity through that commissioning cycle. And commissioners and service users, service providers can both use that and complete it together, essentially. Next slide. So I've just let the links to both the guide and the assessment tool in the chat, and we could, on the slides, and we can put them in the chat. And I'll pause there for any questions before I hand over to Tanya. I'll just have a look in the chat. What's the difference between the equity self-assessment tool and the equity health impact assessment? So the equity health impact assessment, I believe, is from the NHS, and that's it's a separate tool. This is a framework that we've developed using the 10 principles, and Joe's popped her hand up.
Yeah, I was just about to say, actually, good question, Chris. So really the questions in there help you do an EHIA. They're the sort of questions you should be asking yourself. So they are similar. You don't have to be doing an EHIA to answer those questions. You could be doing that when you're looking at a service or a pathway separately. But when you do an EHIA, the questions are very similar, but it's about what is the impact that of other populations you serve in that respect. So I would read them side by side and help you in any EHIAs that people are doing.
Thank you, Joe. Great. If there's no other questions, I'll then hand over to Tanya. We'll be talking about strategic commissioning in Sussex.
Thank you. So my name is Tanya Brown-Griffith. I'm the Director for Joint Commissioning and Integrated Community Teams Development in Brighton and Hove. So I'm going to talk to you a little bit about strategic commissioning on the basis that I helped to develop the strategic commissioning development work stream, which is part of our Sussex Commissioning for Improving Lives Together. And that's our strategy, Improving Lives Together, Sussex strategy. So the next slide just really takes you through a story. You know, how did we get to where we are in terms of focusing on strategic commissioning and looking at the journey that ICBs have been on, obviously from the NHS started to where we are now. And just note that the ICBs were established under the Health and Care Act. Principles were about obviously integrating services, supporting joint ways of working, improving health outcomes, addressing inequalities, and ensuring that we balance equity in terms of financial as well as delivery of services. The next slide then just takes you through to some of the powers and duties and how those have changed with time, obviously, as we shifted from PCTs to sort of CCGs and obviously now as ICBs. And as you can see there, it's very clear that there is a real shift to integrated ways of working and a real shift to reduce siloed ways of working and a real shift to improve and address inequalities and improve population health outcomes. And if we move to the next slide, it just really tells you in terms of NHS Sussex, so where are we in how we're looking at how we commission services and how do we use some of the legislation, some of the strategies or plans and policies. Just of note that we do have a strategic commissioning framework, which is on the intranet. We also have a strategic commissioning policy. So I will drop those links in the chat, but I just wanted you to know that in Sussex, we're ahead of the game with developing our policy and developing our framework, which will guide you whatever role you're in, clinical or non-clinical. So if we move on to the next slide, it starts to give you a sense. So what is it that's changing really? And how do we adapt the ways we work in order to respond to that change? And as you can see there, that, you know, NHS England has been moving towards that collaborative way of working, integrated ways of working. From we saw the 5-year forward view, then we obviously have the NHS guidance this year. We also have the NHS 10-year plan, and all of the language still is around collaboration, still is around integrated ways of working, and still is around moving away from more of a tactical one-year commissioning into more of a longer-term sustained strategic commissioning. So that the policy in terms of our local policies, in terms of how our commissioners work, in terms of how we work with our providers, and certainly how we work with our communities need to shift in order for us to truly commission in a strategic way. And we have really good examples in Sussex about how we've begun to shift that over the last couple of years. And we've got two examples that you will hear about later on around some of our particular transformation programs. So I think we just need to note that this is not just a Sussex program, this is a national program. And NHS England have just released their strategic commissioning framework. This will be sort of formally launched over Q1 of 25-26. And they've also hinted that they will have a national development program for strategic commissioning, which we can all access. And we can all sort of see how we then align to the national, but also deliver our local aims and objectives around population improvement. The next slide was really helpfully done by the King's Fund. And it just tells you, because it seems theoretical, what does it actually mean to move and shift from what we're doing now and do more of what we need to do for the future. And as you can see, some of the sort of highlights there is that we will need to focus much more on a population health outcome, not on a sort of tactical counting numbers and widgets. It's about what outcomes are we improving for the population and how are we measuring those needs-based outcomes. We're also looking at ensuring that we move away from just monitoring organizational performance or provider performance, and we look at system-wide performance. And each of our providers through the Provider Collaborative have an equal stake in ensuring that as a system, we're improving population health and outcomes. So moving to the next slide, really starts to think about, so how do we build on what we have in place already? What are some of the current challenges of how we're working currently in many areas in a sort of more tactical way? And therefore, as you can see, there are many challenges to how we currently work in some of our services. Not in all, as I said, really, really pleased that over the last 2 years, we've begun to shift from that tactical way of counting specific number of people commissioned, number of people delivering a service, to actually looking at what are the outcomes we want to see delivered through the commissioning of these services. So as you can see, it's not provider focused as we're currently doing now. We need to move to it being population focused. Current ways of working mean that we focus on very little patient experience and quality of service. And that will obviously mean that we have people telling their stories multiple times because we have gaps between different provision or different commissioning. And as I said, this is not always the case. We have begun some really good ways of working. And obviously, we know tactical ways of commissioning means that we're probably not using the resources to the best use for our population, and there are many missed opportunities. And we can also, when we develop service specification, exclude providers, which then disables and disempowers our providers in that sort of delivery and equal stake in what we set out to deliver. So if we think about moving away from that, and we've got a very colourful commissioning wheel on the next slide, which sort of just takes you through the different components. So the commissioning cycle itself doesn't change, but it's how we utilize a cycle and how we focus particularly on how we strategically plan, how do we procure service, and how do we monitor and evaluate. And the next slide tells you really how we do that differently. So when you think of planning, it's not just planning, it's strategically planning. It's planning for 5 to 10 year period. It's planning commissioning services that will be for the longer term rather than for the next year ahead. And we're not all in that space yet, but we're moving and shifting to that space. In strategic planning, one of the key components is about assessing needs and looking at data-led. And I think that's what population health management is about, ensuring that we're using data and insights community feedback, community engagement to guide how we procure services for the future. And that takes us into the contracting of services. Developing service specifications for very long has been commissioner-led. The plan to strategic commissioning is that it will be a co-produced specification with providers, ensuring that we start out from a point of need, but we look at ensuring that our providers have an equal stake in developing services and then in developing the outcomes that we will need to measure and evaluate. And that takes us to the monitoring and evaluation. And obviously ensuring that, purchase services are delivered in line with the contract specification is good, quality, quantity, and price, but it's more so about, are we meeting the outcomes for population groups that we set out to deliver? If we move on to the next slide, it really tells us some of the key elements that you'd expect to see in strategic commissioning. Some are already there in tactical commissioning, but it's going further and faster when we think about how we work in longer term planning, how we involve partners, providers in terms of the partnership at service description point, and obviously in terms of service specification. A big ask is that the specific focus on addressing health inequalities, more so looking at health equity. And colleagues before mentioned what that involves in terms of looking at equity and the tools that are available for us in terms of equality health impact assessments, but also the self-assessment. Really helpful because it helps to shift people into that space of thinking on population outcomes and not just an individual or a service pathway outcome. And if we move on to the next slide, it really just starts to then say, so some of the benefits that you'd want to expect to see around strategic commissioning are based on different levels. So at an individual people or patient level, it's about health and care outcomes. And at the economy end, it's about financial outcomes. If we work closer, more integratedly in partnership with people, communities, and providers, we will develop a way of working that releases financial costs. We will duplicate less. We will have clearer pathways. We will ensure there are no gaps. People will be seen in the right places and not have an overburden on critical care or urgent services. And that really supports the national shift to move from just developing care because of gaps, but thinking futuristically, move in services to improve prevention, for example, move in services that are meeting the needs of local population. And most of you would have heard of the neighborhood health guidelines, which has accompanied the planning guidance for this year. And then the last two slides really just touches on the fact that we do have the strategic commissioning policy I mentioned before. It has different components. It is really focused on collaboration and integrating, but also on accountability and the whole systems development approach. If we move on to the next slide, the components of the framework which accompanies the policy have strategic planning, and it does go into detail on what it means to assess population need. How do we seek and improve accessing patient and public insights? We've got the Insights Bank on our intranet, and I think it's being utilized, but not enough. And that is a way of ensuring that what you do for the future involves data, and that includes hard data, but also insights, community engagement, feedback, community experience, patient experience. And in procuring services, it really starts to focus on how do you develop and design services, knowing the population needs, knowing what services are already out there, and deciding the priorities. How do we ensure that our planning in terms of capacity and demand are not just for the next year ahead, but for the longer term? And then lastly, the framework goes into monitoring and evaluating, ensuring that we're measuring performance, not in a sort of a linear way, but we're looking at population health and outcomes for the long term. And then lastly, the next slide really just helps us to focus on what we can start doing more of. What do we need to do to lean into strategic commissioning more? Each of our roles lean into this. So there isn't any role, whether you're an admin or whether you're in clinical role, whether you're in a managerial role, whether you're delivering services on the front line. these roles really are important for you to understand that each of your roles lean into strategic commissioning. Whether it's about a clinical role deciding priorities, identifying a gap, getting involved in designing services, or whether it's in terms of completing equality health impact assessments as commissioners, also involving providers, reaching out to communities, accessing the insights bank, starting to think about what data we have already that shows we're performing well or not, and how do we utilize data sources, public health data sources, to ensure that we plan for the future. And then lastly, there will be some mandatory training around strategic commissioning coming for the Sussex system. Not yet ready, but just watch that space. But most people, for commissioners especially, would have completed the new procurement mandatory training, which really starts to improve knowledge and skills, particularly around provider selection regime, how we procure services for the future. I think I'll stop there and open for questions.
Thank you, Tanya. That was really helpful. There's one question in the chat for you, which is the Insights Bank available for external partners? That's from an Insights Officer, Active Sussex.
I will need to check on that and come back, but it is open for all our stakeholder and partners. So I would need to ensure that we just double check on that. But Joe, I think that it is accessible to our stakeholders and partners.
Yeah, I believe so, but we'll double check for that.
Thank you. We can send that through with our comms, follow-up comms. Okay, any other questions for Tanya? If not, we will move along to Anne, who will be talking to us about community mental health transformation, a fantastic local case study. So over to you, Anne.
Thanks very much, everybody. Nice to be here. So, right, I'm sharing my own slides. They've gone, haven't they? Yeah, let's bring them up. So what I'm going to talk about is a real life situation. So you've heard a lot from Lucy and Tanya and Joe about kind of some of the theoretical side of things. So I wanted to talk to you about what we have done so far in mental health, so you can start to see how some of the things that have been talked about apply in a real life situation. Okay, so I do want to make sure there's an opportunity for some of your questions. So I'll try not to talk too much at you. I think it's the questions about, well, how does this relate in real life to something that you may be working on? Because it's easy to hear the theory, it's how you translate it. So I should just start off by talking through a little bit about what we did, and then over to you for questions. So this picture here, I think, really nicely summarises what it's like in community mental health, or what it has been like. I think mental health is a really big area of need. We know that up to 40% of GP consultations relate to mental health, so it's significant. And the system that we've got, or have had in Sussex, is really disjointed, and it's largely based on diagnosis. And that doesn't work for people that have multiple needs, and actually can be really traumatizing for somebody with mental health, as they have to go through a system that assesses once for a particular thing and once for something else. So you may be somebody, I don't know, you've got an eating disorder, but you also have bipolar, and actually you go one route through for your eating disorder, one route through for your bipolar. But you also may have some issues with housing that is really affecting your mental health, and the system just doesn't work. And actually how we're working, not only is that not good for individuals, it's not the best use of our resource, because it's really inefficient. Lots of individual services having to talk to each other. And we know because of this, up to about 25% of referrals from GPs are not accepted into the system, because we don't have this holistic approach. And I think it's fair to say we don't have enough attention to addressing health inequalities. We have really good community and voluntary sector in Sussex, and they do lots of brilliant work around addressing health inequalities. But the clinical offer is broadly a one-size-fits-all. So we don't have enough of that, and there's not enough attention on prevention. So this picture here, you can see there's like a quote from somebody: "I'm feeling too exhausted, I'm going to give up." And actually, that's what it feels like. So we know when we speak to people that use our services, what they say is it's really hard to navigate. We don't know where to go. We're just giving up. And what often happens then is people become more unwell and then end up presenting in crisis, going to our emergency departments. So not a fantastic system from the starting point. So back in 2019, it was nationally recognised. So the things that I've talked about for Sussex, they are not unique to Sussex. They're happening broadly across the country. So back in 2019, there was a national mandate. At the time, we had a long-term plan, and there was a requirement for every single area across England to transform mental health services and develop an integrated care offer at a neighbourhood level. And that really sung to us, because actually we could see that could address some of the problems that we'd detected in Sussex, we knew were going on. And so this picture here is designed to show what the vision is. And really it's about joining up all the different agencies that are involved in providing mental health care and putting a service user and carer and their holistic needs at the heart. So actually, mental health provision, we've got multiple agencies involved. We've got primary care, primarily GPs, secondary care, that's broadly our large mental health trust in Sussex, so Sussex Partnership Foundation Trust. Third sector is not necessarily a term that we use in Sussex, but it's a community and voluntary sector, and of course local authorities. And all of those different agencies have a really crucial role, and it's really important that we put service users at the heart. I put a link on the side to a video. There's a really nice, it's only a 5-minute video, but it's a really nice video that kind of encapsulates what the aspirations for the future are. And so we're talking about transformation, taking from a system that's really disconnected and is not working as well as it could, so transforming it. And I really like this picture because it kind of summarizes what I think, having been through it and still in it, what transformation about. I think it's very much about a culture shift. So it's getting away from organizations or services saying, no, we can't deal with this. Our boundaries for our service are like this. It's really putting the service user at the heart. And I think co-production, doing things together, and that's really been one of the key landing points for us within mental health. It's no one agency or one organisation's job to do it. We get the best results by working together. So I'll talk a little bit about how we went through the co-production process. So within Sussex, so this national document came out in 2019. And if people can remember, we had that thing called COVID fairly soon after. And actually, we weren't proactively doing the transformation. So if you think 2019 is a long time ago, but actually we didn't really start to get into it properly until about 2021, 22, when we were outside that period of lockdowns and all of the things that were happening in the system. So within Sussex, this is really large scale, and it's all about the whole system change. So we needed a longer term approach. We couldn't change from what the system was at the moment to how we wanted it to be overnight. So we recognised from the beginning this was a long-term plan. And just to give you an idea of the scale, 39 PCNs in Sussex, we've got 50 plus BCSCs, so that's community and voluntary sector organisations in Sussex. We've got many more than that, but those are the ones that actively play a role in delivering and supporting mental health. We have 3 different local authorities. We have a single mental health trust, so that's Sussex Partner Foundation Trust, but it delivers differently into each of the 3 places. So that's the 3 local authority areas. So it's not identical. And we have 3 lived experience groups as well. And that's been really key to us, having lived experience in the process. So the approach that we took from the start was very much recognising this was about multi-agency collaboration. and also shared leadership. We took an approach which was a Sussex framework, but we have delivery within each of the 3 places. And that's recognising that Sussex is a really big geographic area. There are many different needs in each area. And one of the things that we wanted to address was addressing those very local health needs, starting to address some of the health inequalities. So a Sussex-wide framework with flexibility to address those local health needs. And we took broadly a 2-staged approach. So the first stage was very much around building and testing, and the second phase was about redesign. So I'll talk you through a little bit about each of those phases. So the first phase, I think I don't want to emphasize enough around building co-production. It doesn't just happen. So you can't say, let's just co-produce something and it magically happens. A lot of it is about building trust between the multiple agencies. And you saw from that slide at the beginning, there are many different agencies. So, and each coming from their own perspective. And even within community and voluntary sector, you have multiple organisations, multiple GP practices. So it takes time to do that and build trust between the partners. I think critical to what we were doing was recruiting lived experience. So we had 3 lived experience groups and we commissioned them to specifically work with us. And I think it was really important that we tried as far as possible to recruit a huge variety of different people. So it wasn't one person, a tokenistic one person that just sat on a group. We had a wide variety of group who each could bring their own experience. We did a huge amount of work with them. In terms of the VCSE, we, NHS Sussex, awarded contracts to the VCSE to be a strategic partner. And that was really important because I think there was a feeling that actually most mental health provision is Sussex Partnership Foundation Trust, who are a very large organisation, have got a big infrastructure. The community and voluntary sector don't have an equivalent infrastructure, so we awarded contracts so they could be an equal partner in the process. So that was really important. We did a huge amount with general practice. That was really, really important because actually we're talking about neighbourhood levels. So much mental health, the initial input comes through general practice. So we had a huge amount of work going on with general practice. And then there was much broader engagement with communities, other sectors, and we very much tried to use existing groups. And it was around creating that shared vision. So although there was a kind of national mandate of what we needed to do, we need to localise that for Sussex. And actually all the partners created that shared vision, but that took time. It didn't just materialise, but actually what we've got now is a vision that is owned by all stakeholders. It's not one organisation on another imposing something on each other. So that was really important. And I think a little bit around the role of the Commissioner. I think at this initial stage, I think the Commissioner had quite a pivotal role because we were very much connecting all the various agencies. And I think a big part of what we were doing is reminding organisations that this was all about service users. Service users need to remain at the centre of transformation. We're not doing this big scale change just to rearrange deck chairs. It's to do something quite different and to transform. So I think we had a really key role in that first stage. So the first stage was about building, but also about testing. So as well as building the co-production, we wanted to test out how we to do things differently. So we started back in 2022 with developing what we called an emotional wellbeing service. So what we wanted to test out was a fairly small scale, was a new integrated mental health service within general practice. So we were fortunate enough at that point to have some additional transformation funding that came through nationally. So what that enabled us to do was test out multi-agency teams. So the teams were staffed by Sussex Partnership Foundation Trust and the community and voluntary sector based in general practice. So we started to test out at a really small scale this new way of working. And we built, any of you that work or know West Sussex may have heard of the Pathfinder collaborative service model. So we utilised some of those principles. And so I think one of the key things was around, so this was new. We didn't take away any of the existing services. So this was on top. Key thing was around flexibility in terms of access. So we weren't saying, well, you have to meet this particular diagnostic category to access. It was much more generic. And it started to test out different ways of working. And there's put a couple of quotes there from people that have used that. So very much in this first phase, co-production, testing small scale. Are the key things we did. And here just some of the things. There was a huge amount of learning from this first phase, but here just some of the key things to share with you. I think the first thing to say, so an emotional wellbeing service, it was voluntary for general practice to participate. There was variable interest. Not every GP practice wanted such a service. So we ended up with about 2/3 of PCNs working with us. We still face difficulties in recruiting clinical staff. I think everybody knows across the NHS there are difficulties recruiting clinical staff, so mental health is no different. We did find that actually that was difficult, so we need to be much more flexible about different roles. We needed to be creative, linking with other services. So that was there within this, that didn't go away. And I think although we had additional funding coming through nationally, it wasn't really enough to fully allocate according to need at PCN level. So these were really small teams, 2 or 3 people in each PCN. So you can see by the time that's worked through, it didn't give us enough funding to fully allocate at this first stage. The services were quite small, so there were issues about sustainability. However, on the positive side, these services really did start to meet some of the gap. And I think crucially, started testing out a different way of working. So GPs working with Sussex Partnership and community and voluntary sector, it started to test out how we could work in quite a different way. So that's some of the learning from the kind of the testing of the emotional wellbeing service. I put a section on the kind of cultural aspects because I think this shouldn't be underestimated. So we've got multiple organisations and service users working together for the first time. And that was really interesting. So I think all of the partners were absolutely supportive of the need to transform. So there was no dissent. Everybody agreed we needed to do things differently. But I think there were real difference in terms of expectation, primarily around pace of change. I think particularly general practice, they're used to working in kind of small businesses, having an idea, next week, next month, putting that into practice. And so they're expecting things to happen really, really quickly. And I think service users too were. And then you compare that with a bigger NHS trust who has much more complex governance procedures, things were not happening as quickly as possible. So I think that was one of the kind of key things around expectations, around how quickly we were to do things. And I think there were some issues around ownership of the clinical roles. So these clinical roles were in general practice. Actually, general practice wanted much more ownership of their roles because they were working with them. So there was lots of things in that cultural bucket to think through. And then I put the last one around data recording and reporting. So not only there were softer cultural things, there was the kind of harder stuff around data recording and reporting. Actually, there were multiple different systems. And actually, we're trying to create a new team. We want the team to be able to use a single system. So lots of learning there. Right, phase 2. So phase 2 is all about redesigning what we've got. So phase 1 was adding and co-producing. So we're into phase 2. So this diagram here is the model for community mental health for Sussex. So it's around integrating, it's around connecting, vision statements there, but it's also recognizing that people have different needs at different points, and that's what the rings are. So I'll come on to the next slide. So I should say this second phase, we're still currently in it. So I don't want people to think we're absolutely complete. So these neighbourhood mental health teams are going to be going live fully on the 1st of April this year. I've talked a bit about the co-produce model. I think now that we're in a redesign phase, I think a lot of the work focused very much into operational delivery. So we've agreed what we want to do. We now need to change operational teams. And I think this has been really significant in terms of scale and complexity, particularly for Sussex Partnership Foundation Trust, our major mental health provider. Sussex Partnership have recently gone through a major leadership and staff consultation to map all of their staff to the new neighbourhood mental health teams. Alongside this, there's been lots of work around the integrated community teams within Sussex. So these programmes were happening in parallel. We've done a lot of work now to connect into integrated community teams. So when we talk about neighbourhood mental health teams, these are going to be part of the new integrated community teams. I've mentioned system financial challenges because when we started this, we're in a really different financial environment. And I think actually that needs to be considered. And I would say the last point on this slide is role of commissioners. So this, you can see this has been over a number of years, has changed over that period of time. We've moved from a kind of very much a multi-agency planning stage to now what is very much operational focus. And I think as a commissioner, I see our role changing towards an enabler, as providers have very much developed their stronger working relationships. So that's just a few key bits about this second stage. And then I'm just going to wrap up and hopefully leave time for questions. Just some of the key points from this presentation is that whole system transformation, it takes time and requires a significant amount of capacity. So that's a key point. And I think, as I've just mentioned, the commissioner role actually changes over the time of the transformation programme. Co-production has been absolutely key and can lead to better outcomes for us. But I think it's got to be recognised that actually co-production requires some sort of enabling investment to make that work. It doesn't just happen. Testing first, I've talked you through a little bit about the emotional wellbeing service. So that's a key point. Transformation doesn't progress neatly. That's the other thing. We've heard the slides at the beginning, and it all seems neat in cycles. When you're in it, in the real world, it's not as neat as that. And I think I would say you've got to continuously listen, learn, and adapt. What seems like a fantastic idea at the moment might not progress as neatly as that. Think about the culture as well as the infrastructure. And then the last point on that, I think creating the vision is one thing, and actually that's something we don't tend to struggle with. What I have found really hard in this is translating this vision into operational delivery, and that's where I see the real challenge being for us. So that is the end of the slides. Thank you for listening.
Thank you so much, Anne. That was really interesting and insightful. I will open up for questions if people want to put them in the chat. And there's a couple of things that have come through. So one point to note is the importance of emergency care and ambulance services as being mental health providers as well. And then we've got a couple of other points around the integration of physical health and mental health services, which Tanya has come back on in the chat. But there was another point around clinical training and workforce development needs, and to what degree that's kind of being planned out, and physical health and mental health staff have got varying quality, I suppose, and probably access to different training as well. I don't know if it's possible to come back on any of those.
Lucy, would it be helpful if I talked a little bit about the connect between mental health and physical health?
Yeah.
Was that helpful? So we started this work on mental health quite a while ago integrated community teams came up alongside that. What we've been doing now is very much thinking about neighbourhood mental health teams being part of the integrated community teams. So think of mental health as maybe we're doing a first stage. The next bit will be around connecting with physical health, if that helps conceptualise it a bit for people.
Thank you, Anne. I'll just pause if there's any other questions, if people want to put them in the chat or raise your hand. Okay, Tanya?
I just wanted to come on the point that the sort of Karen raises around the sort of workforce training and development, and yes, I agree with her that the sort of clinical training for mental health is still separate to the sort of clinical training for physical health to some respect. But I think, as Anne mentioned, through the development of the ICTs and that MDT way of working, we will have to design integrated training programs, and that is at its infancy, agreed. But thank you, Karen. It only adds fuel to what we know we need to change. And that's about the culture, the behaviours, the training is part of that.
Thank you, Tanya. So it sounds like it's all heading in the right direction, and opportunities for people to get involved as things progress. And we are at time now for our break. So if there's no other questions, I'd like to thank the speakers so far. Thank you for joining, and hope you found it insightful so far and that you will come back after the break. So if we come back at 11:10, where we'll hear from our next speaker. So hopefully you're back, and we will dive straight back in and welcome our next speaker, Charlotte Rogers. He'll be providing a local case study on rehab and reablement. So over to you, Charlotte.
Thanks very much indeed. And I'm just going to share my slides. So thank you very much indeed for inviting me to talk about our programme. As you said, my name is Charlotte, and I'm a Senior Manager for Community Commissioning and Transformation within the Community and Urgent Care Commissioning and Transformation team, and I'm the Programme Manager for the Rehab and Reablement Programme. So just to start, the definition of rehabilitation is the process which helps people to get back, keep or improve their physical, mental or cognitive abilities needed for daily life. It also aims to give people what they need to recover after an illness, injury or disability, and reablement helps people to relearn how to do daily activities and supports them to be as independent as possible at home, and this is all delivered through a person-focused partnership approach. So I'm going to talk to you today about our programme, which is an example of strategic commissioning. This programme is Sussex-wide and has a regional and national focus too. It's been formally up and running for just 18 months, and in that time you'll see that we have set up our programme, socialised it, and have already delivered on some projects, as well as developed a cultural programme of change by starting our community of practice. Our vision and aims are to reduce health inequalities, maximise outcomes for people with rehab and reablement needs, and increase our services responsiveness. We're a cultural programme of change, a convener, bringing everyone together to work collaboratively to consider transformation and improvement through a needs-led and proportionate methodology lens. As a system resource, we can also be called upon for our expertise and advice, and are already linked in with many other programmes such as Discharge. So over the next 15 minutes, I'm going to take you through the importance of our clinical leadership and how this drives and moulds the programme, and what we are doing to build our vision and plans and how we're realising them, and what we plan to do in the future going forward. So at the foundation, this is about drawing on the experience of those both using and delivering services. So bringing in those perspectives and voices that help us to better interpret and understand the challenges and opportunities to inform us on the work that needs to be done, what we need to do more of, what may need to change, and what simply doesn't work for here and now. It also should help us to feel the shape of the future, so moving from a process approach to an organic, iterative model. Through using clinically led approaches, we have better insight on how we translate and interpret national plans, visions or policy, and we can look more curiously in how we approach the design and build of local solutions, enabling us to get it right first time by drawing on not just the data, but the storytelling and narrative of our population and workforce delivering care every day. By developing a unified and clinically led rehab and reablement programme, Sussex has been a frontrunner where we're not just following and embedding national plans, but leading and shaping those strategic directions nationally. This is evidenced through informing NHS England's intermediate care framework. One of our clinical leads has been asked input into the House of Lords Special Inquiry on integrated community teams, also to present on the importance of access to rehab at NHS Confed last year with a National Director of Discharge, and lastly, to join an expert panel to contribute to the 10-year plan for the NHS. So these are real accolades for Sussex. So here's our core programme team, and you can see it's clinically led by Karen and Steffi, who offer us 3 full days of leadership a week between them, and Meg is our key contact in adult social care to ensure reablement is very much part of the picture. How did we get here today to this partnership between a clinical change approach and commissioning? On your screens is a timeline of how the programme has evolved and how the learning from other pathways, and in particular the pandemic and its aftermath, we have been able to better see and understand the impacts of multimorbidity on the wider determinants of health. The programme development has been informed by an audit of people's needs in hospital during the months of the pandemic, and also learning from the long-term conditions programmes in relation to reducing variation and inequality in access to services. With early commissioning support, these programmes looked with curiosity at need and not diagnostic or commissioning criteria, offering Sussex a new way to design services for our population. There have been a number of drivers in helping us describe and test our clinically informed vision. One such example has been the long COVID service, who unusually were offered a clean slate to design and work with peer partners to develop a model of needs-based provision with personalised care as a central tenet interwoven through it. Their operational model has tested, shaped and refined a proportionate needs-based and tiered methodology for Sussex, and this has caught the attention of many national colleagues, with Sussex asked to share, support and advise other systems across the UK. Our programme priorities ensure that we have our population and our multi-professional workforce at our centre. As a clinically led commissioning programme, the sizable step change is the focus on culture and leadership, supporting and enabling all partners to feel empowered in making changes, bringing together collective wisdom and knowledge to co-design the journey ahead. As our system, our rehab data is poor, probably because there is a lack of national consensus on formal reporting on these services, particularly in relation to how much rehab someone receives, what did that intervention look like, and what difference did it make. There's a whole Pandora's box which we're opening. However, the more we measure, the more insightful our future commissioning will be. This in turn will support us to better understand the size and shape of our workforce, where we need them, what skills we need, and crucially what may be missing. This leads us to that nirvana point of how we keep people living well for as long as possible within their communities, and when they do need hospital care, we can keep them active and get them back home as soon as possible. Our programme outcomes are to reduce the impact of living with disability, so ensuring people are receiving the right intervention, care and support to live their lives well. To improve the quality of lives they lead, are we giving the people the skills, knowledge and confidence they need to manage their own health? Improving access to rehab and reablement, so understanding rehab inequality and improving responsiveness to support at a time that is right for the individual. And finally, to improve our service user experience in accessing rehab and reablement support. Our outcomes offer us the future perfect for where we want to be and which continue to be shaped through our communities of practice. Establishing an understanding of our strategic baseline for these outcomes is being informed through some work streams already underway. Through our clinically led commissioning approach, we have translated and interpreted national plans contextually for Sussex to develop our vision. This has taken time, predating the timeline of this programme, and is a product of the collaboration and learning across our multiple partners, offering us a shared view of how we progress the future design and delivery of services for our population. Through this needs-led, personalised and proportionate approach, we can skill mix and match our workforce to provide the appropriate intervention. This offers us a framework to look more curiously at our current provision, particularly given the rehab inequality that exists for people with similar needs but differing diagnoses. It also ensures that we are productive and fiscally responsible with existing resource and that we have a responsible infrastructure and workforce. Our vision has been supported and endorsed by Professor John Bolton, who was brought in to review the discharge arrangements and provision from our hospitals in Sussex. Our foundation in delivering a clinically led commissioning approach is underpinned by our community of practice, which acts as a convener for collective discussion and exploration to drive future commissioning insights. Our community of practice is co-facilitated by our clinical and care leads and includes 30 identified delegates from every organisation within the integrated care system, including voluntary public and patient partners. This offers our partners an opportunity to participate and work collaboratively with others in shaping how we transform our rehab and reablement offer to our population. These sessions respond to emergent topics, and at its foundation is an ambition to support the delivery of integrated leadership at a practice level, enabling the transfer and dissemination of knowledge, skills and behaviours across our services. And it's been designed around our 4 principles of practice, process, partnership and people. Building relationships and fostering partnerships is an ongoing and evolving process. This is a key area of maturity and growth as we now focus on the partnerships that will support the delivery across our priorities. The programme is not only working directly with many partners to shape the work plans, but also matching up teams, services and colleagues across the integrated care system where there are shared themes and activity. We recognise that there are still many gaps, and through our community of practice, we're collecting contacts and continue to reach out to make those connections. Our ambition right from the start was to have a person with lived experience walking alongside us on our programme journey, but this has been proved hard to realise, but we do have a community ambassador now for our community of practice. Now, moving on to how we are realising our plans, over last winter we collaborated with NHS England and 6 other systems with help from Morehouse Consulting to undertake a workforce pilot to support the delivery of the intermediate care framework. This pilot focused on the design and development of a needs-led capacity and demand workforce tool for intermediate care services. This project is now complete and the tool is available on NHS Futures and can be used to benchmark existing workforce against national and Sussex peers and offers a scenario modelling function, so incredibly helpful as we start to shift and shape our services. Building on this tool, we're continuing our partnership with NHS England and Morehouse to further understand and develop tools to transform how people are discharged into community care. This work is focused on using a describe rather than prescribe approach to understand the care and intervention required and reduce pathway variation and duplication. This work will also offer further insight on workforce capacity and capability modelling for forward planning. Package 1 is about embedding clinical tools to support effective discharge and the Home First approach through the Sussex Transfer of Care dashboard alongside a multi-professional leadership model. There are 2 pilots taking place to support this package across the system, and this will provide needs-led data on people being discharged from hospital. This is in collaboration with the discharge programme. Package 2 is a collaboration with 5 other systems to agree a consensus approach to how we describe people on Pathway 1, which is people who receive care in the community. This will help us to understand need and help us to give appropriate care and is linked with the workforce modelling tool described in Phase 1. Package 3 is about the development of 2 tools to support discharge and commissioning. The clinical visibility tool will help us to see what is available for people in the community, offering us a helicopter view of which service may be missing and where we may have geographical, diagnostic or population accessibility gaps. The second tool will give us data and intelligence to support anticipatory needs-led demand modelling. We want to deliver the appropriate amount of intervention at the right time for the right person to optimise their outcomes, and in the current climate, this is increasingly hard to deliver. As a system, we're finding it challenging to balance the capacity and resource against the rising demand and increasing complexity profile within our population. Through better understanding population need, we're better able to identify the type of intervention people will most benefit from, as well as an understanding of how we can be more informed on social complexity, self-efficacy, and individual vulnerabilities, which impact on our ability to take a more proportionate, risk-informed approach to our use of resource. Through using tools to understand need and support stratification, we're working with colleagues to adopt a tiered level delivery model of intervention matched with the appropriate workforce skill mix. Using the clinical lens, the talented people in the system, the ideas from the clinicians on the ground, and our multidisciplinary team working, plus with national support, this slide depicts our plans to close the gap for rehab and reablement over time. Changing the focus from a pathway or diagnostic lens to a needs-led lens, using a proportionate and tiered matched approach, we hope to close the demand and capacity gap, and these concepts are being tested right now in the system. Through our cultural change programme, we will make changes from the ground up and use data to inform us as to the progress so we can more efficiently use our resources. For the long-term future, we need to shift left, and that means to have more people at home rather than in intermediate care beds. And for that, we need to create sustainable community services using the tiered match models of care. In terms of the commissioning cycle, we need to ensure we're monitoring system-wide performance and providing improvement support over the long term to build, grow and flourish. So I hope I've been able to describe to you the value of a clinically driven system-wide programme. We're proud of the fact that we're the first dedicated programme of our kind in England and seen as a national frontrunner. Testament to this is the amount of calls Karen and Steffi get from other ICBs for help. I think it's important to say that this is in no small part due to some very strategic thinkers in the ICB and providers who have driven the investment and support from NHS Sussex for the programme. In terms of what we still need to do, we really do want to land our patient and public involvement, to have a selection of people with lived experience with us on our journey. With the far-reaching remit of this programme, we're concentrating on examining opportunities with the emerging integrated community teams, and also to ensure we have the right data and financial information that we need to make resourcing decisions. We also have big ambitions to get even better communications out to the system. And lastly, our governance isn't quite set as yet, but we hope it will be soon. So the programme is an enabler for integration across the system, and we have hopes that there will be some real commissioning benefits in the future, which will improve the lives of our population. So thank you very much for listening, and I'd be very pleased to take any questions. Thank you.
Thank you, Charlotte. That's really insightful and great to see how data has been utilised and to take the programme forwards, and appreciating the need for co-production, integration and workforce needs as well, in order to better tailor services to local needs. So really fantastic example. Thank you. I'll open the floor to any questions if anyone wants to come in. There's nothing in the chat at the minute. Or people can put their hand up. Joe.
Yeah, it's not a question, just while people are maybe thinking, but just to reinforce, it's been quite exemplary, hasn't it, around the data, about really people jointly understanding the data across the services in relation to rehab and reablement, and being able to use that proactively clinically. So it's not just about, as Tanya said before, about counting how many people have gone through the door. It's actually what type of people and what are their needs, and what and how can we work together to do it. I know we invested some health inequality allocation funding into the tool itself, so I'm really pleased with the outcomes of that, and it's a really well-deserved programme to have some investment in to be able to get us to where we are in relation to that.
Great, thank you. Okay, if there's no other questions, and if you do think of anything, do feel free to follow up, and we're happy to take those offline. So thank you, Charlotte, for your time as well. So before we go on for reflections, if we can go back to the Slido.
Thank you, Lucy, and thank you everyone for spending the morning with us while we present to you on equitable commissioning approach in Sussex. So I think what's really important, and what I'd like you to take away from, if you remember what Lucy was saying at the beginning around the equity approach, and that's a really good useful document that's been shared by Lucy, that's been developed by HIKSS, and also the links that Tanya have put in the chat, into helping you not only if you're commissioning, but also if you're delivering a service, or you're responsible for arranging how someone arrives in a ward, in a clinic, or the patients that you're seeing, and understanding how we can best meet their needs. I think it's around us also, it's about us working together, and I think we've heard from all three of them, three of our speakers, of Charlotte, Tanya and Anne, about people not doing things in isolation anymore, and us all working as a team, and as a team seeking out what people's knowledge and clinical expertise is in certain areas, but also what is our community's understanding and what do people know about the population that we serve. Now, Sussex is a big area, it's geographically large and 1.8 million people in it, and each of us will focus on a certain part of Sussex. So my role is Sussex wide, but I know people may be focusing in Brighton, in East Sussex and West Sussex, then even down into local communities, depending on what their role is. Each of those areas, it's important that we understand the population we serve. So look at the data that we have, and if you need more help to access that, please get in contact with us. But equally, Graham quite rightly puts in the chat that public health in all the three places have a large resource of data and information, and joint strategic needs assessments are produced on a number of topics, and Graham's put something in the chat around the mental health one, I believe was done in West Sussex, if I remember rightly from the link. So I think it's really important. I think the conversation that Anne led in relation to mental health, really important for us to understand that people with serious mental illness live 20 years less years than the general population. They die 20 years on average younger, and that's quite often due to their circumstances that their mental health may lead them to. And also it's down to diagnostic overshadowing, which someone also mentioned in the chat. We do only look at someone's mental health quite often when they present, and quite often we don't look at maybe the underlying cause or a cause that's been shadowed by their mental illness. So we do need to think about that population, and the ICTs are a great example about how those two services, from community services and mental health services, are joining together at a community level to address that. So you've been given quite a lot of information, especially around the strategic commissioning cycle from Tanya. There's great resources in there. You may not understand it all. Please let us know if you need anything more education around that, but ask your colleagues as well. But remember, we all have a role to play in each part of that cycle. So it's not just about contracting. It's not just about counting people. It's about really understanding our population, understanding our clinical evidence base, and understanding what we really need to be doing to make sure that we level the playing field for people, that we increase people's opportunities to improve their outcomes, because we understand they are different, and what that difference might need in relation to their clinical outcomes and life expectancy and healthy life expectancy, which is very important to us. So thank you. So when you're going back to your places, if you could bear the question in mind, keep it in mind, what difference can I make? What is it my population or the people that we are seeing? What the questions can I ask myself around those people that walk through the door or that I'm developing a service for? What is it they specifically need? Is it different to what we're delivering now? Can we do any reasonable adjustments to make it easier or better for people to access, to have a better experience, to really understand their conditions, and ultimately to improve their outcomes? So thank you ever so much for attending, and appreciate to Lucy, to Anne, to Tanya, to Charlotte for sharing their information with us and their experiences with us. And thank you for spending this morning with us, and we hope that you've taken some more learning from where you were when you started. So thank you everybody, and have a good day.
Thank you, Jo. And just before everyone jumps off, I've just popped in the chat the next webinar, webinar 5, which is on case studies in operational excellence. So if you've not already registered, please do go ahead to that link and register for our final session, final webinar for this year's Sussex Population Health Academy. Okay, thanks all for joining, and hopefully we will see you next time.